Good afternoon, everyone. I'm Ruby Hawker with the American Lung Association in Minnesota. Welcome to the 2016 Asthma Webinar Series. Thank you to United Health Foundation for supporting this series, and a special welcome to our United Health Foundation partners and Asthma Action Coalitions joining us across the Upper Midwest. Before we get started, we have a few housekeeping items to cover. All lines are muted. If you have questions during or at the end of the presentation, please use the chat box function in the lower right-hand corner. A copy of the recording of today's webinar will be shared with all participants. Please feel free to share with your colleagues, and all the webinars from this series are available on the American Lung Association of the Upper Midwest YouTube page. Now I would like to welcome Dr. Nadia Krupp, Assistant Professor of Clinical Pediatrics at Indiana University School of Medicine. Dr. Krupp received her MD from the University of Pennsylvania in Philadelphia. And in 2016, she was a Children's Hospital Association Quality and Safety Award semifinalist for multifaceted interventions to reduce 30-day pediatric asthma-related readmissions. Thank you again for joining us today, and I will turn it over to Dr. Krupp.
Good afternoon, everybody. I'm really excited to be able to talk to all of you about asthma and mental health. It is something that has recently become an area of focus for us in our severe asthma clinic, and so we've been paying a lot of attention to it. I am, of course, a pediatrician and a pediatric pulmonologist, so most of what I'll cover today is pediatric related, but it does have a lot of crossover and relevance to adult care as well. So even if you don't see children, hopefully you'll find something useful. First off, I'll just go over a brief overview. We'll go over a couple definitions throughout this presentation. We'll focus obviously on mental health as it relates to asthma and some evidence that there is currently in the literature on this topic. And then towards the end we'll go into some treatment implications, particularly for difficult to treat asthma. So I view asthma as a jigsaw puzzle, and the more complex the patient is, then the more pieces there are to put together. The pieces change. They change in how important they are. They change in what their content is over time. They're not static. So we're constantly building this picture of what goes into a child's asthma care. The pieces that we think about the most commonly are related to medications and adherence and environmental controls. And so when you have a situation where you've already addressed those factors of the child's asthma care and they're still not under good control, then that's when you might actually be dealing with some mental health issues, at least as something to consider. So patients with asthma have an increased risk of mental health disorders. I'll go to in a little bit more detail on that in just a minute. It does affect both adults and children, and it impacts their asthma care in various ways. With children, childhood asthma is associated with higher rates of school absenteeism, ADHD, learning disability, depression, anxiety, and exposure to stress and violence. And the risk of these mental health comorbidities increases with asthma severity. There's a question of whether this is just association or if it could potentially be causation, and if it is causative, then by what mechanism is it causative? There are obviously treatment implications if you have both asthma and mental health issues at the same time. So starting off for school absenteeism, there are more school days missed for children who have asthma versus children who don't, which is not surprising. They do have a chronic illness. But what is a little bit surprising, at least to me, is the number of children with asthma who miss a significant amount of school each year. On this chart, you can see over here, this is children who have missed 16 days or more of school per year, and 11% of children with asthma actually missed that many days of school. That's almost a month's worth of school per school year. If your asthma is uncontrolled, you're much more likely to miss school than if your asthma is well controlled. When you look at how this affects school achievement or how asthma affects school achievement, there was actually quite an interesting study from New Zealand where they took children who were entering school for the first time at the age of 5. They looked at their reading scores on enrollment at the beginning of the school year, and they looked at their reading achievement at the end of the school year. And they stratified it by children who had asthma versus those who did not. And it turned out that children who had asthma had a lower reading achievement at the end of the school year, which was independent of their socioeconomic status, and interestingly was actually independent of their absenteeism. So even once you accounted for the fact that they had missed more school days and you compared children who missed the same amount of school per year to each other, the ones who had asthma did worse on reading. Which then gets to, is there a link between asthma and problems with learning? The worse your asthma is controlled, then the more likely you are to have a learning disability or some difficulty with cognitive functioning. Again, this is not completely explained by absenteeism or by socioeconomic status. Your risk of learning disability is still higher when you account for those things. There has been a thought put out there that has not been proven one way or the other that school performance could be related to the frequency of nighttime awakenings and sleep disruption, where you're not able to get that full restful sleep for your brain to recover from the day if your sleep is broken up because of breathing issues. That has not been very well studied yet at all. So when you move away from school performance and you start looking a little bit more broadly at mental health, this was a survey here in the United States a little over 10 years ago now that looked at children who have asthma versus those who do not. And they looked at ADHD, depression, anxiety, conduct problems, learning disabilities, all kinds of things. And almost all of them were higher in children who have asthma. Let's see, ADHD is up here, was about twice as high in prevalence for children who have asthma. Depression or anxiety was a little over twice as high. Behavior or conduct problems about twice as high. And a learning disability was about 60% higher for those with asthma versus those who do not have asthma. They stratified this by asthma severity. Now this is not necessarily severity in the same way that we think about it in NHLBI guidelines. This is not mild, moderate, or severe persistent. This is how much trouble their asthma is causing them on a day-to-day basis. So if their asthma is only causing them a little bit of trouble, then they're in this column. If the parent perceives the asthma is causing them a lot of trouble on a daily basis, they're over here. And so when you stratify it by that symptom burden, then you see a pretty clear increase in the prevalence of these mental health comorbidities in children who are having more trouble with asthma. These are odds ratios, which means that the children who have a lot of trouble with their asthma have almost a threefold higher frequency of ADHD, almost fivefold higher frequency of depression or anxiety, and so on down the line, compared to children who do not have asthma. One of the things that's striking to me is the number of missed school days in the last 12 months. They were 13 times more likely to miss more than 10 days of school in the last school year. And this one, they were over twice as likely to have repeated a grade. This is another study that looked at asthma severity, but this one is actually broken down by those NHLBI guidelines of intermittent or mild, moderate, severe, persistent. This one looked at anxiety separate from depression to see which one was a bit more common, and clearly anxiety is more common than the depression symptoms up here, at least in this population. If you look at ADHD a little bit more closely, there have been several studies around the world that have looked at the relationship between ADHD and depression, or ADHD and asthma. If you're 50% more likely to have ADHD if you have an allergic disease, including asthma. And the converse is true, is that you're 50% more likely to have asthma if you have a diagnosis of ADHD. This was true in a large international study that included patients in U.S. and Taiwan, Thailand, and the Netherlands pooled together. They had similar results when they looked in Norway, when they looked at 25,000 asthmatics compared to those who did not have asthma. So we've seen it around the world. One of the questions is why. And so in Sweden, they actually did a very large twin study, which they were able to do in Sweden because they have one national database of all of their patients and residents, and so they were able to pull information on very large numbers of patients fairly quickly. So they took over 1,000 twins, started studying them at the age of 8, and followed them until they were 13 years old. And they compared those with asthma versus those who do not, and then looked at they did some genetic studies as well, because some of these were identical twins and some were not. What they found is that those who had asthma, who had a similar increase in their risk of ADHD symptoms compared to the other studies we just saw at the age of 8, that increased by the time they were 13, so that they had almost 3 times higher rate of having more than 3 ADHD symptoms, so probably meeting diagnostic criteria for ADHD at that point. They did keep track of asthma medications, and this was independent of their asthma medication. So it didn't matter whether they were on long-acting beta agonists or steroids at the time, or taking frequent albuterol. This was independent of that. When they looked at the genetics, they were able to estimate that about 68% of this association was probably due to genetic influences. It was unclear exactly how they were related, but it didn't seem to be coincidence, they were able to conclude. It's not sure whether the asthma and ADHD genes are closely located next to each other on the genome, or if they share common pathways, or what, but it was quite interesting. You start looking at depression and anxiety, in that Norwegian study I referenced a minute ago, similar increase in depression and anxiety symptoms for asthmatics versus not, around 50% more likely to have those symptoms compared to non-asthmatics. In the U.S., again, we're looking at about twice as high for depression and anxiety compared to non-asthmatics, higher in those that are poorly controlled. If you improve the asthma control, then it does seem to improve the depression and anxiety a little bit, but it doesn't completely reverse it. This is age 5 to 11. This is looking at a more selected population looking at depression and anxiety. This is an inner city asthmatic clinic, so not necessarily your general population. It was selected to be kids who were a little bit more severe and under poorer control. And they did have a higher healthcare utilization than other children in that same physical area of the city. These are what they did is that they screened for depression and anxiety, and then followed that up with a more robust assessment to see if they probably did meet DSM-4 criteria for depression and anxiety, to validate the screening tools that they used. They ended up finding that a little bit over 20% of this population did have probably met criteria for a DSM-4 criteria of some kind of psychiatric problem. Most commonly was panic. Separation anxiety was also on the list. Depression was a little bit lower. Again, these are younger children. So this will be a little bit different probably when you start looking at teenagers and adults. if you start looking at parents, maternal stress during pregnancy actually has been associated with a higher rate of infant wheezing and a higher risk of having a diagnosis of asthma for the child. When you start looking at the causation of this, it does seem to be associated with elevated IgE levels and is skewing towards Th2, so the allergic inflammatory cascade. These studies have to be taken a little bit with a grain of salt because they didn't quite control for tobacco smoking as a potential mediator, which has been known to influence some of these results as well. After the child is born, if you look at parental depression, it has been associated with a higher likelihood to visit the emergency room and have higher healthcare utilization compared to those who did not report depressive symptoms. And this seems to be independent of the child's health status. So they can have, say, mild intermittent or mild persistent asthma that seems to be objectively fairly well controlled. If you have two children in that situation and one parent is depressed and one is not, the parent with depression will use the emergency room more on average. When you start looking at adults, you see similar patterns. Severe asthmatics have higher rates of anxiety and depression compared to the general population. And again, the odds increase with asthma severity. Similar thing for depression in adults with asthma. Patients with severe asthma are actually about 4 times more likely to have significant depression symptoms compared to those who don't have asthma. So it appears that perhaps depression is weighs a little bit more in adults compared to the young children that we saw where anxiety was more predominant than depression. Again, depression symptoms correlate with severity. But in adults at least, when you account for control and you determine whether their asthma is, say, severe persistent but controlled versus severe persistent and uncontrolled, the degree of control seems to be more important than the actual severity of their underlying disease. So depression and anxiety can impact asthma in various ways. It affects adherence to medications. Some of the symptoms can overlap. It can have strong emotions can trigger asthma flares and asthma symptoms for some people. But one of the questions are there other mechanisms that exist to explain some of this relationship? So when people start to look at causation, we've had some interesting findings. This was a study just a few years ago looking at children who have either asthma or depression or neither or both. They were enrolled when they were preteen and followed until they were age 16. And they actually enrolled a fairly large number of children, over 1,000 children, who have data on a asthma diagnosis one way or the other on file so they could stratify them. They did CRP, which is one of the early inflammatory markers that we see for acute inflammation, and did analysis for various groups to see if they have different elevations in CRP. This is overall for the entire population. This bar right here is a CRP greater than 1, so the percent of patients who had a CRP greater than 1, which is above the upper limit of normal. This is for the percentage who has a CRP greater than 2 and the percentage that has a CRP greater than 3. And of course, the higher your threshold, then the lower percentage of people who reach them. This is for their entire population. This is the group of children who had no asthma and no depression. The children who have asthma, they tend to be a little bit higher. The children who have depression, they might be a little bit higher. And then the children who have both asthma and depression are way up here. And about 50% of them actually have an elevated CRP, and most of those have a significantly elevated CRP. When you look at chronic stress and how that relates to inflammation, you can see in multiple disease settings, not just in asthma, elevations and alterations in the levels of IL-6, TNF-alpha, IL-1, and CRP. So CRP is not the only one that we can blame for this. what is postulated to happen is that this can be your initial response to stress when you have an inflammatory response. If you're sensitized and have a maladaptive response to stress, then with repeated stressors, the inflammatory effect actually is augmented. And so your subsequent inflammatory response is actually higher than your initial response. This is one potential mechanism. To partially explore this, this study did some work in a mouse model where mice were sensitized to an allergen and given an inhaled allergen challenge to mimic an asthma flare. Some of those mice were exposed to a stress situation where they were not allowed to socialize with the other mice, because some mice are apparently very social animals, which causes them some significant emotional distress. And then they sensitized and challenged both sets of mice, those who were stressed and those who were not. And those who were stressed and sensitized seem to have different responses in their inflammatory pathways. Over here, particularly we can look at this one. This is IL-4, which is one of those Th2 cytokines that is related to allergic inflammation. This is baseline when they start. These are most of the groups of mice, and at this time 0 is when they were actually given some steroids to try to resolve the inflammatory response that they'd simulated in these mice through the allergen challenge. So here they give them no steroids, and then these are increasing doses of steroids as we go along. This is the set of the group of mice who were sensitized and under stress. And instead of their IL-4 levels decreasing in response to increasing doses of steroids, this actually shows that their IL-4 increases instead. IL-5 is similarly a Th2-related cytokine, and it doesn't increase necessarily, but it stayed steady over time, whereas the others did drop as was expected. They did a separate group looked at college students and who had known mild allergic asthma. Did a similar thing that they did in mice, where they did an inhaled allergen challenge, but they did it during 2 periods of time, during low stress and high stress, to see if they had different inflammatory responses, and they measured sputum eosinophils, blood eosinophils, and some other blood biomarkers. This is the blood eosinophil count here. This is at baseline, so this is before when they were not under stress, and this is when they are under stress here. This is 6 hours after the allergen challenge, 24 hours after, and then 7 days after the allergen challenge. So if you just look at the white bars first, this is when they're not under stress. Their blood eosinophils rise a little bit. They come up to about 3% maybe, and then drop back down. When they are under stress, they are started off at baseline higher, baseline significantly higher up here, close to 3, and then had an augmented response up close to 6%, and then came down a little bit, but didn't quite come back down to where they started off with at baseline. The periods of stress that they examined were either at the beginning of the college year when they haven't had any exams or anything like that, versus later on in the college year, right around midterms. So this is interesting as well. This is, again, looking at stress. This is a functional MRI that were done in asthmatics. And they had them view asthma-related words, so things like difficulty breathing and chest pain and shortness of breath through the little goggles that you can look in when you're having an MRI done. They were looking for areas of the brain that light up in response to those words, and they saw this area right here, which is in the insula and the anterior cingulate cortex. What they noticed when they did a allergen challenge to these patients after the MRI is that the brighter the spot was, the greater decrease they saw in their FEV1 in response to that allergen challenge, and the greater increase in peripheral eosinophils they saw, again, in response to that allergen challenge. So there seems to be some kind of connection with how strongly this part of the brain responds to stress and what it does to the lungs and to the inflammatory cascade. And related to stress can be exposure to violence. And so this study looked at cities with higher levels of inner city violence compared to those who have a lower level of inner city violence. They looked at asthma control days. So this is actually the number of symptom days they have per month. And the lighter bars are those who have almost no violence exposure in the inner city. And then as they increase, the violence increases until you get to this bar where there's the highest level of violence exposure. All these different sets of bars basically represent different models where they tried to control for almost anything they could think of. They tried to control for socioeconomic status, tobacco smoking, medication usage, distance to a highway, amount of outdoor air pollution, as many things like that as they could. And basically the model still held and showed that the cities with the highest rates of inner city violence the children had a larger number of asthma symptom days compared to those who were exposed to less. The one thing this did correlate with is that if the family was afraid enough to let the child go outside, then they had a higher rate of asthma symptom days. So we put together a few more pieces of our puzzle. We've talked about education and achievement and mental health disorders and exposure to stress. Now the question is begged, what do we do about this? So the first thing we can do is identify whether this is a problem or not for our patients. We can consider screening for our high-risk groups in particular. We may not want to screen every asthmatic. That would be a lot of screening to be done if we did that. Perhaps we could do it for those whose asthma is refractory to treatment or their symptom severity is not quite fitting with our objective measures like their pulmonary function tests. And if we're going to screen, then at least in children, we would screen for depression, anxiety, and probably school performance issues. In adults, probably depression, anxiety, and not so much school performance, but there are other quality of life measures to see if they have trouble engaging in work and things like that. There aren't many studies in the literature at all on treatment of mental health disorders and whether that actually improves asthma control. The only ones I was able to find are a couple case reports that include self-hypnosis or relaxation breathing, and that does seem to improve asthma control, but that's a little bit different than what we're talking about. We're talking about DSM-4 criteria met psychiatric problems, which is different, although these could be potentially adjunctive therapies. If there is an anxiety component or panic attacks that could be mistaken for asthma, that has been described as being quite helpful, obviously, to identify which one you're dealing with and try to address the right problem. But short of that, there's not really much out there. As we said before, the presence of mental health factors can affect adherence, the disease process itself, as we saw in the inflammatory cascade work that's been done. Also symptoms and the ability to engage in a treatment plan. If the patient or the parent has significant depression, for example, they may have trouble having the will and the get up and go every day to be able to engage and problem solve with you for how they're going to make their asthma better, or they may not feel that it's worth it. They may feel that it's hopeless anyway. All of these factors can affect the ability to get asthma symptoms under control and get somebody well. This brings us to difficult to treat asthma versus severe refractory asthma. These can look like each other, where you feel like your patient is having the same amount of trouble or even more trouble with their asthma despite escalations in therapy. Difficult to treat asthma is much, much more common than severe refractory asthma. Difficult to treat asthma includes issues with adherence, environment, exposures, comorbidities, and mental health issues could be a part of that, where if you were able to magically remove all those factors from this patient's life, then their asthma could be well controlled. Severe refractory asthma is where you've already addressed all of those things, minimized them, or completely gotten them out of the equation, and the asthma is still very, very difficult to control. So if you have somebody with difficult to treat asthma and they seem to have potentially some mental health issues, the question is where to start. Like I said, you could screen. And if you screen and somebody screens positive, then you need a mechanism for evaluating for potential mental health comorbidities and confirming whether that's a real problem or not. You can assess the patient or the family's coping skills, and very importantly, make sure that you assess their readiness to seek help, whether they're ready to acknowledge this could be a problem or not. Coping is defined as the ability to basically apprise a situation, have an emotional response, and then figure out what you're going to do with that emotional response, and then act on it appropriately. As you can see down here, whenever we're presented with a difficult situation, all of us in our brains, we may happen very quickly, but there is a primary appraisal of what happens, emotions that are triggered. Then you have the secondary appraisal of, I'm feeling anxious, now what do I do? And then that's where coping comes in, is to have the skills to be able to manage that emotion and be able to act appropriately and constructively. There are adaptive and maladaptive ways to cope. Maladaptive include denial, particularly when the diagnosis or medications or the advice that they receive conflict with the beliefs they already have. And that all of that can lead to decreased adherence and difficulty engaging with a family or a patient. There have been some studies that have looked at coping and whether improving coping skills in difficult-to-treat asthmatics can actually help their asthma control. There's a little bit of data on this, but not a lot. Most of it has focused on behavioral self-management and empowering patients and families and giving them some the tools and some skills to be able to deal with emotional situations. The studies that have been done do seem to show improvement in nocturnal symptoms, in activity limitations, and also in school absenteeism. Motivational interviewing can be helpful as well. This is focused on self-management, self-efficacy, and can improve adherence, although there's no one magic bullet for adherence, but this can be helpful. For those of you who are not familiar, motivational interviewing is a collaborative and goal-oriented approach to trying to elicit change in someone who's ambivalent about change. On the one hand, they would like to change a behavior, but on the other hand, they're finding it difficult or don't want to change it for another reason. This strategy and technique emphasizes the autonomy of the patient and emphasizes the fact that they are the only one who can make this decision. Nobody can do it for them. It includes 5 basic principles that look at empathy, avoiding argument, but developing discrepancies. And so if you have a situation where they say things that are juxtaposed to each other or in conflict with each other, you basically point that out and say, that's interesting. On the one hand, you seem to feel this, and on the other hand, you seem to feel that. Tell me more. Examples of questions that are used in motivational interviewing are, the first is that you ask permission. So you say, do you mind if we talk about your smoking for a minute, for example? And if they say no, then you can proceed and say, yes, I actually do mind. I'd rather not talk about it. Then it's probably not worth engaging in the rest of what you had planned to talk about because they're clearly not ready to listen. So you can bring it up again the next time you see them, perhaps. And then you try to get them to go through the mental exercise themselves about what would be different if they did change a behavior versus what would the outcomes be if they continued with the behavior that they have, and then develop the ambivalence and the discrepancies that you find along the way. And acknowledging the fact that this is difficult to make a change and that other people find it difficult to make a change as well. And respectfully asking them what they've tried before, what has worked, what has not, and what their thoughts are about trying to change that again in the future. So back to screening. If you start screening and evaluating for mental health problems in an asthma population, then you have to be prepared for the results. So you'd need to be prepared for the instance that you could have somebody who has a psychiatric emergency who says that they are actually suicidal or have had homicidal ideations, and you need a plan for that. Hopefully it wouldn't happen, but you wouldn't want to get in that situation and have never thought about that before. Also having a set referral plan will be important so that you know where to refer people on and you have realistic resources that they can get in and can get in a timely manner to see a mental health provider. This may require additional support personnel if you plan on doing something like this in your clinical practice, a social worker or a psychologist or a psychiatrist or maybe some combination thereof. We recently started screening for mental health disorders in our severe asthma clinic, and we have actually had to use our suicidal ideation pathway, our algorithm, to work through that, actually on the first day of screening, which was quite interesting. It may be useful to do, but you need to be a bit thoughtful about how you implement something like this and make sure that you have the tools to be able to support what you find. So in summary, mental health disorders are anywhere between 1.3 and 3 times more likely in children and adults who have asthma compared to those who do not have asthma. The incidence seems to increase with a higher degree of severity and also with poorer asthma control. So the worse your asthma is and the poorer it's controlled, the more likely you are to have some kind of mental health disorder. Seems to be more heavily weighted towards anxiety and potentially ADHD in children, although depression seems to be a bit more prevalent perhaps in adults, although there's not a lot of data that I was able to find in the adult population that teased out depression versus anxiety in them. Stress seems to augment the inflammatory response and also seems to change how the body responds to therapies that we use, including steroids. And so this could be a contributing factor to the severity of asthma in our high-risk populations who are under constant chronic stress. So if you have a severe asthma population or a difficult-to-treat asthma population that you care for, you can consider screening for psychosocial comorbidities and mental health problems in those patients, but be ready for what you find would be my advice. And I have a lot of references listed here, which is in very, very small type, but I'm happy to send them to anybody who needs them. We have some time left for questions now.
One question. Did you already advise specific screening tools?
There are, as I discovered when we started screening in our population, there are at least dozens, if not 100 or so more screening tools that you can use for children and adults. We ended up picking, for our population, we ended up picking the PHQ-9 and the GAD-7 for screening, partly because they are validated in adolescents and also partly because they're easy to fill out. We have a population that struggles with literacy, and so we didn't want anything that was too overwhelming that has 45 questions or takes an hour. These are pretty quick. They're pretty succinct, and the verbiage used in them is pretty easy. If you want it to be a little bit, those only look at depression and anxiety. They don't screen for ADHD and conduct disorders and other kind of things. If you want to screen for those, then you could use the pediatric symptom checklist, or there are a couple others that are a little bit more in depth on those other mental health disorders. But we decided to focus on depression and anxiety, so that's what we ended up using. But again, it kind of depends on your population and which question you're trying to answer, and whether you think your patient population would have the time and the literacy level to be able to sit down and actually go through something that's 45 questions and can take half an hour to fill out on their own.
Have there been any studies done showing treating the anxiety or depression symptoms have made a difference?
No, there haven't yet. And that's one thing that is an area that probably needs to be looked at. Most of the studies that have been done, if not all of them, have looked at prevalence of mental health disorders and asthma, and have been more cross-sectional in nature, where they're looking for associations. But there haven't really been many that have looked at, if you intervene at point X, then if you fast forward, say 6 months or a year, does their asthma control improve? That's something I think needs to be done, but it hasn't been done yet.
I want to thank Dr. Krupp for joining us today, and we will certainly follow up with a recording, and I really hope you all share what you learned today. Thank you.